Assalamu alaikum. I'm just waiting for the presentation. Okay. So I'm going to talk about conduction disturbances after TAVI and techniques to reduce risk of PPM. I have nothing to disclose. So the outline of my talk, I will be talking about anatomic relationship between the conduction system and aortic valve complex, incidence, predictors, and outcomes of conduction disturbances, management, and finally, cusp overlap technique to reduce risk of PPM. So, conduction disturbances after TAVI, this is really the most frequent complication after TAVI. And we have seen only modest reduction with newer generation valves. So really not much has changed. And it is associated with prolonged hospital stay, higher cost, and potentially worse clinical outcomes. So here you can see the relationship between the aortic valve and the conduction system. So if you can see between the right and the non-coronary cusp, you have the interleaflet triangle, and just below that you have the membranous septum. Below the membranous septum is the central fibrous body from which the conduction system is arising as it arises from the AV node in the right atrium and its way as it crosses to the left ventricle. So it's in a very close proximity. And this is why you see the previous speaker, Dr. Ahmed, talking about the length of the membranous septum, and actually even the shape of it can determine risk of pacemaker. So here you can see the conduction system just below the membranous septum. This is the rate of pacemakers after TAVI. This is from the TVT SDS ACC registry. Thank you. And as you can see, actually, the PPM risk is actually increased from 2011 to 2015. So this increase is probably because of change in the design of the valve. So as we're trying to combat BVL, we are getting outer skirts, and also we are getting more radial forces to prevent BVL at the expense of the conduction system, as you can see. Now, over time, the risk is coming down a little bit, probably because we are implanting valves in lower risk patients, and also further refinement of the technique, going for higher implantation. This is the register from France. This is about 49,000 patients. And as you can see, they have self-expanding valve with a little bit higher risk for BBM as compared to balloon expandable valves. So you see the risk at about 30 days is about 20.7% for balloon expandable versus 25.5% for the self-expanding valve. Generally much higher than what we observed in other trials. This is a real data. This is like registry, so real practice data. And you see here only the 30 days, but in most studies you see the 30 days outcome, but here you see the outcome up to 4 years, and you see how much increase in pacemaker rate over time for all valves. Now you see that the older generation versus the newer generation, early on, the difference is really minimal. But over time, newer generation is actually causing more pacemakers compared to the older generation because of all the reasons I have mentioned before. This is the largest comparison between self-expanding and balloon expanding valves, center collaboration. The problem is this is not a randomized control trial, so it's not really free of confounding and bias. But here you can see the difference in permanent pacemaker, 7.8% for balloon expandable valve versus 20.3% for the self-expanding valve. I have to show you this slide because this is showing you the incidence of new left bundle branch block after TAVI in main registers and RCTs for different devices, different studies. So in general, you see that self-expanding valve has a little bit higher risk as compared to balloon expandable valves. But what is important that I want to show you here is if you look at the bottom, for example, and you take Sapien 3 valve, just one device, multiple studies, you see the variation in the risk from something like 5 to 8% for some studies, up to more than 20% in other patients, in other studies. So this difference is due to different patient population, different implantation technique, and also different threshold. Sorry, this is a left bundle branch block. So we talk about different threshold for pacemaker implantation between different centers, but this is for the LBB. So that thing is not applied really. The good thing, where we have to bring some good news. So this is from Sweden, the Swedish Heart Registry, and you see survival in patients with and without pacemakers is really unchanged. There is no difference in mortality in this study. But this area still needs to be studied because there are other trials, like for example this one, showing all over mortality is the same, cardiovascular mortality is the same, but the heart failure hospitalization is higher in patients who had pacemaker implantation, and they are actually using their pacemaker. So the pacing burden is more than 30% at 1 year. In those patients, you can see readmission for heart failure in the left bottom chart. You can see is higher for patients who are using their RV pacing more frequently. Also, those patients, they will have lower ejection fraction, and they have higher AFib burden at 1 year. So it's not really completely benign, this RV pacing. So maybe it's time to start talking about maybe bundled branch pacing. This is maybe another good news is that you see most patients who implant pacemakers, they don't use their pacemaker, or they are not pacemaker dependent over the long run. So you see this is different meta-analysis from different studies, and at 1 year, almost 50% of these patients are no longer pacemaker dependent. Talking about the predictors, they are many, but the most frequently cited is the pre-existing right bundle branch block. But you have so many other EKG clinical demographics, especially the age and male patient. You have, of course, the procedural, especially the type of valve and the implantation depth, also oversizing, pre and post dilatation. And anatomical, you already heard about the membranous septum length and also the distribution of calcium, the location and distribution of calcium, because I showed you in the CT the relationship between the conduction system and the aortic valve. So this is the expert consensus guidelines. So here you can see that for every patient we have to evaluate the risk of conduction disturbances. Usually if there is no ECG changes and no pre-existing right bundle branch block, you don't even need to do pacing. This is minimal TAVI, no pacing. You just do telemetry for 24 hours or overnight. For patients who are having some changes or pre-existing right bundle branch block, temporary pacing for at least 24 hours or overnight. And then you have to decide what you want to do. More observation, you go with pacemaker, or you do some electrophysiology study. There is really no consensus of what to do for those patients. This is the pacing guidelines, European pacing guidelines from 2021. And as you can see, there are two class 1 indication, basically high-grade AV block and new onset alternating bundle branch block. This is class 1. Class 2 for patients with pre-existing right bundle branch block, and they have newer or further deterioration of their conduction system. This is class 2A for patients with left bundle branch block and QR is more than 150 or BR interval more than 240. for those patients, they advocate either ambulatory monitoring for 7 to 30 days or electrophysiological study, both 2A. For patients with pre-existing conduction abnormalities other than right bundle branch block and further prolongation of QRS or PR interval more than 20 milliseconds, then again it's class 2B, really uncertain for ambulatory ECG monitoring and electrophysiology study. Now I will talk about the cusp overlap technique for transcatheter self-expanding aortic valve implantation. And here the idea is to isolate the non-coronary cusp, and you superimpose the other two cusps, the right and the left. And the idea here to expose the lowermost point of the cusp. So you see really the insertion point, and you get appreciation of the true depth of the valve. And usually you start from up, you start implanting from the top, and you keep the marker band mid-pigtail. So the idea is to do top-down deployment. So instead of going into the ventricle and trying to retract the delivery system as you deploy, messing up with the conduction system, you start from above and avoid the conduction system altogether. And then basically you are aiming for about 3 millimeter depth in this view. You can go as low as 1. There are people going even for 0. If it is more than 5, then you should recapture and try again. And once you reach the point of no recapture or 80% valve deployment, then it is mandatory to go and look in the LAO projection, the true coplanar view. You might need to add some LAO to get rid of the parallax, but here you see the things that you are not seeing in the areocaudal, the cusp overlap view. Namely, you want to see the proper depth in the LCC because you want to make sure it's not supraannular in that side. So that's one. Second, you want to see the tension on the catheter and its relationship to the outer and inner curvature. And as you can see here, what they have done is they retracted the LV wire, and the idea of that is to remove any tension as you continue to deploy the valve slowly. So this technique provides high implant and without the risk of the valve popping out. And as you can see, for example, in this study, you see they were able to achieve comparing the conventional technique versus the cusp overlap technique. You end up having higher implantation in the cusp overlap 4.8 in this study versus 5.7. Also, pacemaker risk is cut by half, 23% versus 12%. The same authors, basically, they published a bigger study with propensity matching this time in the JACC, and here you can see they cut the rate of pacemakers from 20.7% in the conventional implantation technique to 11.8%. Now you have similar technique that can be, not cusp overlap, but similar technique you can use for other valves like even balloon expandable valve. And there are some reports of reduction of pacemaker rate to less than 5% in some studies with higher implant. So take-home messages: conduction disturbances after TAVI remains a common complication due to proximity of the conduction system to the aortic valve complex, as we have seen. And there is a lack of unified approach to management due to lack of scientific evidence and dynamic nature of injury and variable time to recovery. So should we put the pacemaker now? Should we wait for 1 week, 2 weeks, 1 month? We don't really know. And high implantation techniques showed promise in reducing risk of PPM. RCTs and further technological advances in valve design is needed to address this problem in the future. Thank you very much.